गुड इवनिंग गणेश.
गुड इवनिंग सर. चालू करते हैं, चलो.
आज नहीं, जस्ट थोड़ा फ्यू रेसिडेंट्स ज्वाइन करें.
सर वो गड़बड़ क्या है ना, अभी वो आईएसयू का वेबिनार अभी खत्म हुआ है, 5 मिनट हुए.
हाँ, मेरे को लगा. आई
मैं
थॉट
भी
सो.
उसमें ज्वाइन था, मतलब तो अभी खत्म हुआ है वो.
हाँ, यू वर द मॉडरेटर ओवर देयर, करेक्ट?
नो 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 नो, आई वाज नॉट देयर. अश्विन और वो था, कौन, केवल पटेल, एक मेरा अहमदाबाद का दोस्त है.
हाँ हाँ. सो गणेश, मेरे को आई वांट टू नो फॉर आवर इंडोर ना. I let us, all those who are practicing onco in West Zone, let us make a small group and give the suggestion for I like a subspecialty. I want to do it. Like one is onco, one is how it is there in USI. The same way we'll make it in West Zone. Means our hall A and hall B, like that. So in Indore.
ठीक है सर.
तो
कितना दिन का प्रोग्राम है वो?
दो दिन का, only 2 days.
Okay.
So like I want to give like 3 hours to onco, 3 hours to and alternately we can have it in hall A and hall B, like that. So that we don't have to wait for first for good program to get over. Suppose by chance if it is delayed, the second program starts in hall B. You understand? So in between the podium and all, we can put it into alternatively.
बराबर.
That is the way we can do it. So then we will save the time also, and we can finish it, and little overlapping will be there. So people who are interested in andrology will be joined.
Usually नासिक में एक ही हॉल था ना प्रोग्राम का, कि दो 3 हॉल थे?
3 हॉल थे, but were not utilized.
ओके. नहीं, दैट इज ओके, बिकॉज कई बार मुझे ऐसा लगता है कि यूएसआई में क्या होता है ना कि like I have to sit only in uro-onco, then मतलब अगर मुझे चाहिए भी updates about different things in urology, even if I'm not doing, there is no chance for a person like me. So if we have program in one hall, we can experience probably everything.
हाँ, no, instead of वही मैं बोलता हूँ. For example, 9 to 12 is onco. Then after that, suppose we have got female urology.
बराबर.
If it is in the same hall, then you may be delayed for any reason. But suppose 9 to 12, then 12 to 3 hours we have got in hall B. So by chance, if this is delayed, then those who are interested will immediately go to the female urology side. Our program will continue.
Overlap नहीं रखेंगे, but
नहीं, overlap नहीं. We will not keep it overlapping.
Timing से overlap नहीं रखेंगे.
नहीं, timing से नहीं. It will be alternately, but so that all the programs can start.
ये idea अच्छा है.
And I want you to suggest all the अपना West Zone का those who are in onco, and divide them. Just some people in.
And onco का दूसरा मतलब कैसा रहता है कि बहुत सारे, मतलब एक तो प्योर यूरो ऑन्कोलॉजिस्ट मेरे जैसे, बाकी तो जिधर जिधर रोबोट है सब लोग हाथ लगाते हैं onco करके. वैसे रहता है.
So mainly we want a pure onco, and then when we make a program in that, you can take
no
participants, you can take separately. But I want your ideas and your views. How to.
कब तक बनाना है प्रोग्राम आपको?
बस आप जल्दी बनाओ. Then we can invite people to participate and make a good program.
तो कोई तो और लगेगा ना, लाइक अभी महेंद्र इधर है, कश्यपी
हाँ, कश्यपी है सब.
सर मेरे को एक आइडिया देना, आप कितना आवर्स देने वाले टोटल, ये बताइए.
आई एम कैलकुलेटिंग कंसीडरिंग बोथ द हॉल.
आप बोलेंगे कि 2 घंटा है, तो 2 घंटे में क्रिस्प प्रोग्राम बना सकते.
हाँ, you do it ना. Or you can have 1 hour of for 1 hour for bladder, 1 hour for kidney, 1 hour, like that. I can give you 3 or 4 hours.
वो सर कैसा है ना कि अभी टीचिंग बहुत होता है, तो we will not have the program like a master class where we want to finish every organ A to Z.
No.
We will
What is
take
new?
some niche things, some somewhat common things which people think they know everything, but still get new things in that.
So I want that only.
ठीक
I
है,
want that only.
चलेगा.
So we'll
करते हैं.
just wait for 2 minutes and then we'll start.
Okay, ठीक है sir.
Who is answering today? Ajinkya?
Yes, sir. I'm answering, sir.
And who else?
Shashwat is there, I guess.
Pardon?
Shashwat is there, I guess.
Sashwat is there. Sashwat has joined.
Yeah, he has joined, sir.
Where is Sashwat?
Good evening, sir.
Yes, Sashwat, I am waiting for you.
Yes, sir.
Earlier you used to answer. You are well read. So how is your Julia going on? Fine.
Yes, sir.
Make Dr. Huddedar also co-host. I think we should start now, Ganesh.
Yes sir, चलेगा.
Yeah. So Sashwat and Ajinkya are answering today. Sashwat is from Dhulia and Ajinkya is from Jaslok.
Should I start, sir?
Yeah.
So,
Swastik, you can start.
good evening, everyone. Coming to scenario 1, a 84-year male from Mumbai presented to our OPD with complaints of blood in urine in 1 month and difficulty in passing urine for 1 month.
Okay. So Ajinkya, what are the important points you will ask?
Sir, I'd like to ask the immature upon the onset duration and progress of immature, whether painless or not painful. Whether it is total immature, initial or terminal immature, associated with any clots, was it in sudden onset or was it continuous or intermittent? Then I also would like to evaluate the second complaint, which is difficulty in passing the what difficulty is having in passing urine the IPSS score of the patient. Then I'll also like to have some negative histories like if patient having any fever, any lithuria, pyuria, if patient having any other lower urinary tract symptoms, patient dysuria. Any history of anticoagulations in past history? Any history of similar complaints in past? Any history of any complaints of abdominal distension, jaundice, bone pain, or any complaints of lower limb edema, facial puffiness?
Shashwat, you want to add anything?
Sir, any history of lower urinary tract instrumentation is there or not?
Yeah.
And yes, sir, that's it, sir. And any the episodes were self-limiting, or whether he undertook any treatment for the same?
So you have talked about fever and other thing.
Yes, sir.
So when there is a blood and lower urinary tract symptom, what are the possibility that comes in your mind?
Sir, it could be urothelial malignancy, sir. Probably CA bladder or upper tract tumor, sir. Then, sir, it could be a renal cell cancer, sir. Or it could be, sir, sir, this age is actually a bit higher, but it could be a benign prostatic enlargement with hematuria, or carcinoma prostate, sir. And it could also be, sir, vesical calculus, stone disease, and yes, sir.
Yeah, or it can be a combination like a
Yes, sir.
stone
It
and
could be a
prostate.
combination. Yes,
Yeah.
sir.
Fine. I think that is a good operation. Yeah. Dr. Gite, you want to ask anything?
Sir, फिर directly management पे जाए क्या?
हाँ,
No, sir.
मतलब
Because we have handled this history so many times. So if we go on
Yes, yes, yes.
management, then maybe more cases can be done.
correct.
Better if you are discussing a UTUC, then history related to UTUC. UTUC should be you should tell related to UTUC only, so that you will directly go to the diagnosis and management. So what are the history you ask in a patient having a urothelial upper tract urothelial carcinoma?
Sir, history of smoking is relevant, sir. Tobacco consumption and smoking.
How it is relevant?
Sir, it increases the relative risk of urothelial malignancy, sir.
In case of upper tract urothelial carcinoma, how much is the increase in risk?
Sir, relative risk increases by 2 to 3 times, sir, in smokers as compared to non-smokers. And then apart from that, sir,
So it is
history of
2.5 to 7 times increase in the risk of upper tract urothelial carcinoma, and you have to advise the stoppage of that tobacco
Yes, sir.
chewing or smoking. And in spite of stopping, it will get decreased, but it will not get eliminated.
Yes, sir.
That is the important thing related to the smoking. Any other history?
Family history, sir.
Sir, a personal or a history of
Family.
urothelial malignancy, or family history of Lynch syndrome tumor, sir. Any colorectal, gastrointestinal, and skin tumor, sir.
Ovarian, female.
Ovarian in females.
Any other?
Occupation history, sir.
Question? Amputation.
Occupation.
Occupation. Yeah. Particularly if worldwide, if you consider the worldwide, the Chinese and Taiwanese people are more prone for urothelial carcinomas.
Yes, sir.
Endemic.
History of, sir, alkylating agent chemotherapy, if in the past.
And very important history is history of any surgery or any time diagnosis of having a bladder cancer in the past.
Bladder cancer, sir.
Bladder
Urothelial
cancer.
malignancy in the past.
Okay. So we'll go ahead, sir.
We'll go ahead.
Yes, sir. So should I continue with the slides or?
So you go directly to the physical examination now.
On general examination, the patient was conscious, cooperative, well oriented to time, place, and person. Pulse was 80 beats per minute. BP was 130 by 80 millimeter of mercury. Respiratory rate was 18 per minute. afebrile, and saturation was 98% or room air. There was no evidence of pallor, icterus, sinuses, clubbing, lymphadenopathy, or edema. Spine examination was normal from head to toe. Karnofsky score was 70. So,
So nothing positive.
no, sir.
Again, Shashwat, when you are asking the history related to the locally advanced and metastatic disease of upper urothelial carcinoma, the constitutional symptoms and involvement of the surrounding structures, that history should be included when it is asked in relation to the upper tract urothelial carcinoma. So go next. Aage chalo.
Yes, sir. For abdomen, sir, patient examined in supine position with implanted from considered equal to knee in adequate room light. On inspection, umbilicus centrally placed, all quadrants moving equally with respiration, no scars, sinuses or involved veins seen. On palpation, there was no localized temperature, no tenderness present, bladder was not palpable, and no renal tenderness was there. Percussion, remaining node was present all over the abdomen. Normal liver dullness was dullness span was present, and auscultation, normal bowel sounds were present. So, parietal examination, there was no fissure, fistula, or hemorrhoids. Anatomy was normal. Grade 3 prostatomegaly. Prostate was forming consistency, having smooth surface, and rectal mucosa was mobile. There was no blood on gloves. Respiratory systems, cardiovascular system, and central nervous system examination were grossly normal.
So overall, it is no any other positive finding except the chip complaints. So your diagnosis is still same, or you want to change?
Sir, right, like same differential diagnosis, sir.
How will you go ahead with? How will you evaluate this patient?
Sir, I'd like to request a complete urine examination along with that CBC and PTCT, PT-INR, renal function test, and an ultrasound abdomen and pelvis, sir.
And a Euroflow.
Yes, Ajinkya, what else you want to ask? Urine for cytology also.
Urine for cytology and Euroflow.
Yes. So that will complete the basic work.
And uroflowmetry. Yeah.
Uroflowmetry, urine cytology, ultrasonography, and basic laboratory investigations.
Fine. So Swastik, just show them this result.
Sir. So on investigation, blood investigation, hemoglobin is 11. Total counts were 10,480. Platelet count was 2,13,000. Creatinine was bit raised 1.8. Urine routine was done. RBCs were 10 to 20 per high bar field, and WBCs were 40 to 50 per high bar power field. Should I go ahead? This was the uroflowmetry that was done for the patient. It was suggestive of poor flow rates, and body time was prolonged.
And what about ultrasonography?
Sir, actually, ultrasonography report could not be traced with the patient, but it was suggestive. Could not be traced, sir. We have CT report, sir.
Okay, wait.
Cytopathology also performed, sir. Urine cytopathology was performed. We collected samples on day 1, day 2, and day 3. 40, 50, and 40 ml of urine was collected. And sir, on first day, it showed an occasional atypical cell only. On day 2, there were few mature squamous cells and neutrophils were present. No high grade features were seen, and few atypical cells were there. And similar finding was on the day 3, that few atypical urothelial cells were seen. No high grade features are detected on urine cytopathology.
So here, raised creatinine, clinically widening symptoms, and urine routine shows multiple pus cells.
Sir, culture was done.
And we don't have ultrasound. So how will you go ahead?
Sir, urine culture was performed or not?
You have to ask for that. You have to ask for urine culture. If there is 100 WBC in the high power field, the urine culture is indicated here.
Yes, sir.
And 1.8 creatinine, the ultrasound is mandatory, at least basic.
Yes, sir.
Is there any hydronephrosis? What is the status of upper tract? How much is the post-wide residue? What is the thickness of bladder? Okay. So
Yes,
what is any intravascular extension of the median lobe? How much it is? So all that factors are important because creatinine is 1.8.
Yes, sir.
That may be due to the infective element, or that may be due to the obstructive element.
Yes, sir.
So I will start antibiotic as per the culture, and as per the sonography, I will proceed. Sonography they have not done, and 1.8 creatinine. What next? Cytology is a typical cell again. So do you do you have in that atypical cell does have any importance?
Sir, no, sir. Atypical cell along with squamous cells, sir, they're indicative of contamination, sir. And sir, since creatinine is high, I would like to have an calculation of eGFR, sir, so that we can proceed with the cross-sectional imaging, sir.
Fine. But atypical cells, or what are the criteria you will look after?
Sir, according to the Paris classification, sir, either it could be negative for high-grade urothelial cells, or it could be sir, low-grade urothelial neoplastic cells, or it could be, sir, atypical cells. Then it could be suspicious for high-grade cells, or it could be a positive report for high-grade cells.
So which
So,
sample is better, voided urine sample or barbodex sample?
Sir, barbotage increases the
Barbotage.
yield and as compared to the voided urine, sir.
How much is the sensitivity of voiding and how much is the sensitivity of barbodex?
Sir, sensitivity of voiding is 30 to 60%, sir, but specificity is 100%. And sensitivity is directly related to the high grade of the tumor. Low grade tumors are sensitivity of 20%, whereas high grade have a sensitivity of about 75%, sir.
And in case of barbodex cytology?
Sir, barbotage, I'm not really sure, sir. Sensitivity, specificity.
More than 90%.
Okay, sir.
And what are the things you will look for the cells?
I didn't understand, sir.
What are morphology and other things in the cell you would like to see?
Sir,
Achil, you can answer.
Sir, in cells, we can see features of malignancy such as increased number of mitotic figures, high nuclei to cytoplasm ratio, and increased hyperchromatin within the nucleus itself.
Is it there in that report?
They have
No.
just mentioned atypical cells. Usually, we take atypical cells in our center as suspicious cytology.
We consider that as a malignant cell. Okay, fine. So now next, what you want?
I will hydrate the patient since patient is also non-diabetic.
Let us ask Ganesh. Ganesh, when such a report comes, what is your consideration? What you consider? Ganesh or Mahendra? Mahendra, you are there?
Yes, sir, I am here.
So when such a report comes, how you go about?
Can I say the USG finding? Yes, I want to correct it.
USG was not done.
We don't have USG.
He just
USG
have
nahi hai.
a
If this cytology report comes, then obviously we have to take it with a pinch of salt.
because atypical cells these are plus minus equivocal. They are not 100% sure this is negative, 100% this is the positive cell. And
Is it better to go ahead with barbodex cytology?
It is best to go ahead with the barbodex cytology actually, but we'll have to do a scopy.
Yeah.
And then here I would still ask the patient whether you have given a fresh sample or not.
Agreed.
बाकी कुछ नहीं, क्योंकि sometimes degenerated cells are seen as atypical cells.
Okay.
Because again, no high grade features cannot rule out the presence of malignancy.
True.
Right? And atypical cells can be because of infection, can be a normal finding. It can be misleading actually, right?
Okay.
Okay. Yeah. So again, if it is there, the laboratory sampling is better than having a fresh sample like that. It gives more cells, more exfoliate cells from the bladder, more tissue from the cells from the in the urine.
So in the sonography, it shows that there is a mass in the left renal pelvis. Okay, it is about 3 to 4 centimeters, and there is a hydronephrosis. Right kidney appears to be normal, and there is nothing, no other findings in that. So now, how will you go about? Akhil,
Sir,
you have treated the patient with antibiotic.
yes. So can you repeat the
So I
question?
did- Yeah, the ultrasonography is showing that there is a mass in the space occupying region in the left renal pelvis, about 3 to 4 centimeters, with a hydronephrosis. Right kidney appears to be normal. Corticomedullary differentiation is well maintained. There is no other lesion seen in the abdomen. The prostate is enlarged, and post-void schedule is about 45 to 50 cc.
Sir, in this patient, I would like to get the CT urography because even if the creatinine is 1.8, we will hydrate the patient, and with the risk consent, we can go ahead with CT urography for better delineation of the
How
mass.
much eGFR you are expecting in this patient?
In this
With this creatinine and age.
eGFR will be in between 30 to 60.
Less than 30, sir, or less
60?
than 30, sir.
In between less than 30, we can calculate by Cogrove formula.
Calculate it then.
Weight of the patient is unknown.
Approximately 50-60 किलोमीटर 60-65 kg. उससे ज्यादा तो नहीं रहेगा on an average. या 70 kg 70 year पकड़ लो 70 kg and serum creatinine 1.8. Because with hydration at serum creatinine 1.8 at the age of 74 year.
84.
84. Again, it is very high, na?
Yes.
Very high.
And again, one thing, at the age of 84, creatinine of 1.3, 1.4 also considered high. Right?
Yeah, the GFR will be quite less in that.
Let us ask this question to somebody. Why we are saying so? Why the creatinine should be lesser in elderly person?
Sir, because the muscle mass is lesser, and creatinine is affected by the lean body.
Lean body mass, which starts reducing in elderly age.
Fine. So what are the options now? What are the investigations?
So can one of you sum up what we have positive things in this patient, 84-year-old hematuria? Go on.
Sir, 84-year-old male patient with the hematuria and low unit tract symptoms as chief complaints, and with hypertension, and ultrasound urine cytology consisting atypical cells, and ultrasound showing left renal pelvic mass 3 to 4 centimeters with mild hydronephrosis, with enlarged prostate with 40 ml residual urine.
And 1.8 of creatinine.
Creatinine 1.8. Yes.
So what will you do next? Or how will you approach?
We'll do MRI, sir.
MR urography. MRI with MR urography.
MRI abdomen.
Okay.
You want
MRI.
Sir, go ahead.
Okay.
Because if we do
abdomen, as sir was saying, obviously it should be MR urography. I hope that much is clear.
Yes.
See, what we have done here, that we are going to present, but that doesn't mean that that is the right thing. So we have to learn here from all these. Hello. So now we will present you. Yeah. So we will present you only what we have done. But in this clinic, you have to learn what is mandatory, what answer you will give in exam, and what even in practice you will be doing. Okay. So as Dr. Ganesh and Dr. Gite have suggested.
So Shashwat and who's answering? Achint and Shashwat and
Ajinkya, sir.
Ajinkya. Chalo, all of you answer one question. This patient presented with hematuria. and he has asked MR urography. So I want to put you a scenario, MR urography versus I would do a cystoscopy RGP on that side, and I will also collect urine for cytology. So you say pros, MR urography ke liye one person, Shashwat, you say pros and cons. And
Yes, sir.
Ajinkya, you talk for cystoscopy, RGP, and barbotage, as Gite sir was saying. I feel I'll get almost good information in that also.
Sir, in MR urography, it's cross-sectional imaging, so we can better delineate the T staging, and we
Okay.
can also determine the lymph node status, sir, if they're enlarged. And
So what is the criteria for lymph nodes in the retroperitoneum?
sir, if it's a left-sided tumor, sir, so we'd like to look at the ipsilateral hilar and the paraaortic lymph nodes, sir.
Hilar and paraortic are same, right? If you want to answer it, it should be paraortic, preaortic, and interaortic cable.
Intra-aortic cable. Yes, sir.
Right from the diaphragm to the bifurcation of aorta.
Yes, sir.
See, whenever you think you are going in exam, imagine that you are answering in the templates.
Yes, sir.
Don't pick up a point. Matlab, try to tell the examiner ki, okay, you know ki template kya hai, and then push hilar.
जी sir.
बोलिए आगे.
And sir, sir, since it's a large pelvic tumor, sir, sensitivity will also be equivalent to CT urography, sir. And we can also evaluate the contralateral renal unit and the upper tract. And
तो upper tract की बात तो चल ही रही है.
जी sir.
Always remember, in soft tissue, MRI is always superior to the CT scan.
Yes, sir.
Don't say equivalent. Otherwise, it will be some question, where did you read that? In soft tissue, MRI is always better than the CT scan.
Yes, sir.
Yeah. So what
So
else?
what is not good with your MR urography, or what are the cons?
Sir, CT urography is better for upper tract tumor, sir. Better T staging is afforded with the CT urography, sir. As compared
Actually,
to
वो सवाल नहीं था. सवाल was actually MR urography versus cystoscopy, RGP, and barbotage.
Yes, sir.
I actually didn't add a plain CT to that. Otherwise, it will complete everything.
I agree.
Sir wants to know what is the
See,
benefit
this patient
of
had
doing
hematuria.
MRI?
As one of the mandatory investigations,
Yeah.
we do cystoscopy in urology, no?
Yes, sir.
And this is elderly patient. I don't know, my sonologist has picked up one renal pelvis mass. The incidence of having bladder mass is 34 to 38%. And God knows, if the bladder was empty, there would have been bladder mass also.
Yes, sir.
So let's ask the other person. Ajinkya or Achint, what would you gain
Sir,
by
for-
cystoscopy, RGP, barbotage?
So if you are even if the patient eGFR is less than 30 and if MR urography is not possible, it is better to do a cystoscopy and uroscopy. If you are considering doing this, it is better we use a small scope and a flexible scope. Avoid putting a guide wire. And if you are considering taking a barbotage, it is better to take it before doing an RGP. It will help us to
Why
have
flexible
a
scope? Why not rigid scope? If I can give anesthesia and do, what is wrong with rigid scope?
So we have to be as far as possible traumatic while doing this scopy. So it will be better to.
I think the dictum in urology is you have to be atraumatic in all scopies.
All scopy. Yes,
This is
sir.
a new thing which I have learned today. Superb.
That is generalized a backup answer.
I mean, you are talking like a general surgeon.
Yeah.
Superb. Just for my
So,
information, where do you come from?
in spite of telling like that, Ajinkya, rigid ureteroscopy is made for mid ureter and lower ureter. This mass is in the pelvis, that is in upper
Pelvis.
ureter.
वो छोड़ो मतलब.
Flexible. Yes.
So you should
क्वेश्चन था सिस्टोस्कोपी, आरजीपी एंड बार्बोटच पे. किसने बोला था यूरेट्रोस्कोपी वगैरह बोलने के लिए?
unnecessarily you have involved ureteroscopy.
हाँ, मैं कुछ भी बोलूंगा. I can, as an examiner, I can take you any place.
Agreed. Yeah, defense should be scientific in exam.
बोलो.
If you are answering the, or if you want to involve the flexible scopy, then your answer should be correct. That is radiological investigation as well as cytology. When there is equivocal, then there is a role of flexible scopy, flexible ureteroscopy in case of upper urothelial tract, upper tract urothelial carcinoma. Here, question asked by sir is the cystoscopy versus MRI. Basically, this is the question.
तुम थोड़ा सा माइंड अप्लाई करके उसमें आंसर देने की कोशिश तो करो.
Ajinkya, you just tell him what are the advantages and disadvantages of doing cystoscopy, okay, RGP, and collecting for the cytology.
Or no one is opposing whatever you say. If I would have been in your place, I would have said ki these are two probably separate things. They do complement each other to a certain extent. But given in a case of hematuria in this patient, sometime I am going to do a cystoscopy, RGP, and probably take a barbotage. Whether I go for URS flexible rigid is a different next thing. But if there is a big mass, 4 centimeters, which I can see, say, on the MRI or a plain CT, and if I get a barbotage of that side system, which says high-grade urothelial carcinoma cells, I'll take my decision on that basis. I hope I asked these two questions because I wanted something like this, so that's why I answered that.
Yes, sir.
Yeah. No, I think this is a very good question. It's an eye opener for everyone. And well, so anyway,
sir, I guess, sir, Gaurang sir.
Yeah.
Sir, I want this point, which Dr. Bakshi wants to point out. These students should understand this very well, that imaging and any procedure like cystoscopy, ureteroscopy, and biopsy, as such that they are complementing each other. How? Ajinkya, Ajit, can you just explain how they are complementing each other?
Sir, if the ultrasound shows a renal pelvic mass, the RGP will show a self-swelling defect and will further confirm. And already cytology, we have atypical cells. With barbotage, we can get a definitive finding of high-grade malignancy cells.
Okay, so it is not about MRI, it is about any imaging, either CT scan or MRI plus ureteroscopy, cystoscopy, and the barbotage or the SS biopsy, right? So ureteroscopy, cystoscopy will give you tissue diagnosis, okay? And imaging, either with the CT scan or the MRI, will give you the T or N staging, which is not possible with the ureteroscopy. Right?
And
so
sometimes
again,
if we are going to miss smaller tumors in the imaging, we are going to find them in the cystoscopy 100%.
Like carcinoma in situ, you will not see this thing in the MRI or CT scan, you're not in the CT IVU, right? And you know very well that upper tract starts from the renal pelvis, calyx, to the ureter. Am I right? Yes. And if the carcinoma in situ is there, it can't diagnose with the MRI and MRI CT scan. Okay, and we will go further how it is helpful to have all these things in the management. Okay, this was the point which Bakshi sir want you people to know how to say in the exam and how to justify this. Okay. Yes. Yeah. So now what done after this?
Yeah, no. First thing, you just show them what was done.
Yes, sir. We had done after hydration and with the consent of the patient, we had done a scan for the patient. So this was the non-contrast film. So I have just put different films on the different screen. There are 3 screens for the 3 different films, sir.
So next time, if okay, fine. Okay, go ahead.
This
Yeah.
was the contrast study, and this was the final film, sir.
The bladder, the contrast was given, bladder is filled of urine, or what is it now? Okay,
It is urine in the bladder, and there is a mass seen.
no, it is non-contrast, na CT scan. So what is the ureter?
It is contrast probably.
Contrast.
The first
Yeah.
film was not contrast. The third film-
Contrast with hydration.
Yeah, contrast with
Acha,
hydration.
Okay. So anyone can define the describe CT scan.
But there is a large.
You don't want to see previous film. Show him previous slide, please.
Yes, the first slide. This is the first slide, sir. First scan, sir.
So at least read the CT scan, whatever you are able to see, tell that. Right side kidney, ureter, bladder is normal
Appears
after
normal, sir.
well
This is
rich.
CT abdomen pelvis plain film, sir. The liver and spleen appear normal solid organs. The right kidney normal parenchymal thickness is noted with the pelvic system not dilated. In the left side, the parenchymal thickness is decreased, and there is a space occupying lesion in the renal pelvis with moderate hydronephrosis of the left PC system extending up to the mid ureter, which is evident in the next image, sir. And in contrast film, there is no contrast uptake or there is no contrast excretion of the from the left kidney. Sir. This indicates a
Is there a
non-functioning kidney.
stone in the left kidney? Is there a stone in the left kidney? If I see the lower middle image, is it a stone?
I cannot make out any stone, sir.
Okay. Okay. Yeah. It is
Actually, in the second column, second row, fourth column, we can delineate the pelvis, the mass in the pelvis, the normal PCS, and the thinned out parenchyma.
Right, you're right. Okay, so report दिखा है क्या?
Sir.
and इसमें you should say that the smooth lining, is it irregular lining, but it will indicates again T staging.
Okay.
Yeah. Did you appreciate able to appreciate any nodes in the CT scan?
I was unable to appreciate now.
No nodes.
Okay. Yeah. If you cannot see, please be honest. Okay. Yeah.
Pratik, just read the report.
Yes, sir. So the right kidney appears normal in size, position, shows regular cortical margin. It was measures 10.5 centimeter in length. Prompt description of contrast medium seen in right kidney and renal parenchyma shows uniform enhancement. No evidence of focal lesion, radiodens calculi, or hydronephrosis seen on the right side. Peripheral fat space appear normal on the right side. Right ureter showed normal caliber and course, no intrinsic lesion or calculus in the ureter. Left kidney, there was evidence of an abnormal homogeneously enhancing mass lesion seen involving almost the entire left renal pelvis and extends inferiorly into the proximal ureter, causing moderate degree of hydronephrosis and resulting thinning of renal parenchyma. There is practically no excretion of contrast medium seen in the left kidney, even a delayed scan taken at end of 1 hour. Small radiodens calculi are seen in lower polar calyx in the region of renal pelvis in the left side. And urinary bladder showed normal contour and wall thickness with no evidence of interluminal lesion. Posterior moderately enlarged and seen indenting adjacent bladder base. Few intrinsic focal calcifications noted. Incidentally, multiple sigmoid and descending colonic diverticuli were seen. The impression was findings of neoplastic etiology, possibly transitional cell carcinoma. Few small radiodens calculi in the lower polar calyx of kidney and moderate prostatomegaly.
तो आगे क्या करेंगे बोलिए?
What next?
कोई तो बोलो शाश्वत
Sir,
या
this is a
Akhil, कोई बोलो.
sir, this is
Restart
a
the patient.
high risk, sir. Upper tract urothelial malignancy, sir.
Okay.
And sir, given the age of the patient,
Wait. In malignancy, we always say that there is a rule when you have every investigation. The next step is
But
Restart the patient.
diagnosis and staging.
yes, sir.
diagnosis, staging, followed by somebody just said that word.
Metastatic
Restart
evaluation.
Metastatic thing, it was not done in this patient. It's the only chest was not done. Okay. You have not seen the chest. Suppose that in
Yes.
this is having a two nodules in the lung. So are you treating as a oligometastatic disease like hydroreactive nephrectomy? There is no role. So first thing to see complete staging. Okay. And
Yes.
after that, next step, risk stratification.
Stratification, sir.
So can you tell me what are the criteria of a stratification in the upper tract cancer, and what is the criteria and rules?
For low risk, for it to be low risk, it should be unifocal. The size should be less than 2 centimeter. The cytology should be not high grade. If you're doing a URSN biopsy, it should not be high grade, and the CT should not be suggestive of any invasive features. Or for high risk, it has to be multifocal, more than 2 centimeter in size. It should be high grade on cytology, or in the biopsy. It should have there should be hydronephrosis, any previous history of radical cystectomy for high grade tumor, and CT suggestive of any invasiveness.
Good. So anything important about the low risk?
Sir, all the criteria
All
must
factors should
be
be present.
Yes.
all factors
All
must
should
be
be present to define the low risk.
any one of the factors like multiple
For high
disease,
risk.
size more than 2 centimeter, high grade
This is-
on
yeah.
URS or cytology.
This is very important. And in any malignancy, if there is a stratification, you should always see what is the low risk. Generally, low risk must have all the criteria.
All the
Okay.
Yes.
Yeah. So this is how you should remember about the low risk. Okay.
Yes, sir.
Yeah. So now tell me, now in which category this patient is? Low and high risk.
Sir, high risk.
high risk.
High risk. So we assume that CT chest is normal, right?
Yes, sir. Then high risk localized, sir.
Okay. Now patient is DTPA. करना है इसमें? You want to do DTPS in this patient?
Yes, sir. Actually, calculation of EGFR is important, sir, because if the EGFR is more than 45, at least we can offer fractionated cisplatin neoadjuvant chemotherapy for the patient.
Okay. So all cases of high risk, you would like to do neoadjuvant chemotherapy?
No, sir. Actually, first we'd like to prognosticate based on the preoperative prognostic criteria.
Okay.
And sir, keeping in mind the age of the patient also, and Karnofsky performance score of 70, sir.
Patient is a farmer. He does all his work in the house. He is not dependent at this age.
Sir, in high risk disease, sir, there is evidence of improved survival with the neoadjuvant chemotherapy, sir. So we'd like to offer neoadjuvant chemotherapy.
This is phase 2 trial, right?
Yes, sir.
Okay, fine. So you are planning to give him chemotherapy initially.
Yes, sir.
Only based on DTPS scan.
Sir, actually, we need tissue diagnosis also before proceeding for neoadjuvant chemotherapy, sir. So we'd like to do a flexible ureteroscopy with barbotage specimen for cytology, sir.
That you have done before, na? I think sir was asking the how to complementing the two tests. Complement two tests each other. See imaging and ureteroscopy.
Yes, sir.
So why not upfront surgery in this patient?
Sir, there is definite, sir, because after radical nephrectomy, the GFR of the patient will decrease further, sir. Although on the CT scan, sir, there is no contrast seen, but without a DTPA scan, we cannot be sure, sir, how much contribution is by this side, by the affected side, sir. So,
So do you think at the age of 84, you should see so many things other than focusing on the treatment part?
yes, sir, definitely, sir, because prognostication is very important, sir, because of the advancing age, sir, and he has hypertension also, sir. So, and he's having hydronephrosis also, sir. So these are poor prognostic factors, sir.
Yes. Yes. So age, you should always think about the age, whether he will be fit for chemotherapy or not.
Yes, sir.
Right? Because 84, some high chances not able for chemotherapy, and based on 84, based on his fitness, that means called medical fitness about the surgery, anything. You can plan some other management. You have to decide. At this stage, it should be individualized thing.
Yes, sir.
Okay. Right. Bakshi sir, at this stage, anything else?
Nothing.
Okay,
I mean, we can operate if we get a Barbotas positive, we can operate without a tissue biopsy.
Which chemotherapy you are planning for?
Sir, if the eGFR comes out to be more than 45, then, sir, it is preferable to give MVAC, sir, 4 cycles, and evaluate the response, sir. If the response is there, then 2 further more cycles before going on for surgery, sir.
Why not Genesis? MVAC has more complications.
How much is the chances of having a GFR more than 45? Again, same question.
Less chance, sir. It's unlikely, sir, that it's the GFR the patient will be more than 45, given the age and the creatinine.
Then what is alternative?
Carboplatin.
If you have already planned for neoadjuvant, what is alternative? Is there any alternative?
Sir,
Suppose this patient is ineligible candidate for cisplatin.
Yes, sir.
So what is your plan?
Sir, carboplatin can be given, sir. Gemcitabine carboplatin, sir. Although, sir, trials are going on, it's not a clear-cut recommendation, sir.
Okay. So what is the harms and benefit of doing neoadjuvant chemotherapy, then surgery, and surgery, then giving adjuvant therapy?
If we are giving neoadjuvant chemotherapy, sir, with both the kidneys present, then there is a likely chance that the GFR will be more than 60 and we can give cisplatin-based chemotherapy. But and there is a chance of, sir, downstaging the disease also, and it improving the overall survival and cancer-free survival, sir. But giving chemotherapy for, sir, delay the definitive surgery by more than 12 weeks, which in itself is a adverse prognostic factor, sir.
And what is other negative thing? If this disease is not responsive to chemo, in 12 weeks, the stage may become metastatic. Right?
Metastatic, definitely.
Okay. Fine. So, and what about adjuvant chemotherapy?
Sir, adjuvant chemotherapy by the POUT trial, sir, now it is a strong recommendation, sir, for PT2 to T4 tumors and nodes positive or metastatic, sir. Adjuvant chemotherapy is the recommendation, sir.
So
either MVAC or Gemcis.
So previously you were advocating for the new adjuvant. Now you are in favor of adjuvant. You have a strong evidence of phase 3 trial. So by what basis you are planning for this treatment of this patient?
Sir, actually, given the age and the degree of hydronephrosis of the patient, sir, we have to individualize the treatment for him. And his kidney function is also, sir, total function is also less. So
Mhm.
the treatment plan has to be individualized for this case, sir. So if we are unable to give neoadjuvant, sir, neoadjuvant definitely has a better advantage, sir, and it can downstage the tumor. And
Right. So
but-
everything has its pro and cons,
yes,
right?
sir.
So it should be individualized by seeing all the factors. Okay.
Yes, sir.
So if it is young patient, maybe we will not discuss that much. But is a old patient with 84-year-old. Okay. So best answer, in my opinion, will be to having so many factors which are complicating the treatment options that are discussed in the disease management group, and among the medical oncology and surgeons. Okay.
Yes.
And we have these options. These options are right. You are not wrong in saying these options. Okay.
Sir.
Okay. So suppose that this patient is okay and he opted for the surgery. What will you do?
Sir, a radical nephrectomy with bladder cuff excision with template-based lymph node dissection must be offered, sir.
Like, what do you mean template-based dissection?
Template-based dissection is for the left pelvic tumor, sir. It is the hilar, the para-aortic group of lymph nodes, along with the intra-aortic cable, and from the hilum till the inferior mesenteric artery, sir, on the left
So
side.
it is left side tumor or right side tumor?
Left side.
Left side, sir.
And right
So
side?
for pelvic tumor, which lymph nodes you want to remove?
Sir, from the level of the hilum till the inferior mesenteric artery, sir. Ipsilateral.
Okay. Then that's all. My question was, what were the templates in upper tract cancer?
Sir, for the right-sided pelvic tumor, sir, we would like to remove the hilar, the para cable, retro cable, pre cable, and the intra-aortic cable group from the level of the hilum till the inferior mesenteric artery. And if it is involving the upper 2/3 of the ureter, sir, then we would like to extend the hilar lymph node dissection till the aortic bifurcation, sir. If the tumor involves the lower third of the ureter, sir, we would like to remove the ipsilateral, hypogastric, obturator, external ilia, and the presacral group of lymph node and the common ilia group of lymph nodes.
Yeah. So important part is this: upper ureter, lower ureter, and nasal pelvis all have different template of dissection. Okay.
Yes.
Okay. What? So you want to do lymphadenectomy, and what about bladder cuff? Why it is important to remove bladder cuff?
Sir, most recurrences they occur at the bladder cuff, sir.
Why?
So, sir, because there is a downstream seeding of the tumor, sir, and the field cancerization theory, which says that the tumors are of the upper tract, sir, they are more prone to recur in the lower tract, sir, in the bladder. So that's why the cuff of the bladder must be excised in toto along with the specimen, sir.
So the appropriate answer it would be, because if you don't remove the bladder cuff, the intramural part of the ureter cannot visualize by the cystoscopy. Okay.
Yes, sir.
And that's why you said that the seeding. So there is the most common site of bladder cancer, bladder cuff only, where we leave the ureteric stump. Okay.
Yes,
so that's why we remove the bladder cuff, so that the whatever we see inside from the inside the bladder, it is only the residual mucosa of the unit tract, not the which we left during the surgery.
Yes, sir.
Okay. This is the reason we should remove the bladder cuff.
Yes, sir.
Right.
Yes, sir.
Okay. So which you prefer, open, robotic, or lab?
Sir, this tumor, sir, on the basis of the imaging, sir, it appears to be a T3 tumor, sir. Sir, according to the guidelines, open surgery is preferred. But if expertise is available, sir, then laparoscopy or robotic may also be done, sir.
So what is the harm of laparoscopic and robotic in T3 disease, in such a disease?
Sir, there is a higher chance of bladder recurrence, sir, lower bladder recurrence after radical nephrectomy by using laparoscopic approaches, sir.
Why?
Because, sir, the management of the bladder cuff is not adequate, sir. And
No, I don't
extra
agree with you. Maybe the issue of expertise, not about the
Yeah, but in exam, say
approach.
whatever you are comfortable with or whatever you have seen. Because if
Yes.
somebody asks you this question, it's quite possible that they might go ahead and ask you some more questions in what you are going to tell.
Yes, sir.
Means suppose if I do open, lap, robotic, all three, I can ask you any type of question, whatever you complex you choose.
Yes, sir.
So it's always best to answer what you see in your institution.
Yes, sir.
तो क्या सवाल था महेंद्र जी का?
It was that open laparoscopic and robotic, what is the harm compared to the open surgery? In this scenario where the disease is T3 and we are planning for surgery, what we should care very much taken care of during laparoscopic or robotic surgery. It should not happen in open may one, it is okay, you can manage, but in lap or robotic should not happen actually. It is under pressure system, no?
Yes, sir.
There should be no tumor spillage.
Yes, sir.
During robotic and laparoscopic, there should be no tumor spillage,
Yes, sir.
right?
Yes, sir.
Yeah. Okay. Sir, anything else at this scenario?
Yeah, no, about the investigation. So what are the indications of MRI in these cases?
Sir, MRI is indicated.
If a
MR
CT,
urography indicated if, sir, CT urography cannot be performed because of the low estimated GFR, sir.
if I can do a CT, triphasic CT with IBU component safely, then probably I can read that investigation much better.
Yes, sir. Otherwise, sir, in other scenarios, sir, if probably if it's a in case of pregnancy, sir, probably we can, if we are having
Yeah.
that, then MR must be done, sir. MR is advisable. CT
So
is
that is
contraindicated.
second indication. Third indication.
Sir, history of any contrast allergy.
Yes.
Actually, this should be your first indication.
Yes, sir.
Okay. Any role of FDG PET scan?
Sir, FDG PET scan is better. It has a sensitivity of 82 to 84% for lymph nodes, sir. But for the T staging, sir, cross-sectional imaging with CT and CT urography is, has a higher spatial resolution, sir.
Yeah. Okay.
So now, in this case, Ganesh and Mahendra,
Yes, sir.
because it was a patient had come with a CT and it was a non-functioning kidney and atypical cells were seen. So these three things, we can go ahead with the nephrourectectomy with the cuff of bladder.
Sir, provided he is fit to undergo a surgery.
Yeah, he is fit.
Yeah, definitely. Because chemotherapy has, I think, more complications compared to the surgery, and there is systemic complications. Of maybe if you suppose that he get a good response with the chemotherapy, but again the there will be a question about the fitness of surgery after chemotherapy. So if at this point, if it's chemotherapy and localized disease, if it's okay, we can consider about the adjuvant chemotherapy.
Fine. So that is what we did. We normally do the cystoscopy. We did the cystoscopy. We cut the cuff of bladder around the ureter, and when we did a nephroureterectomy. So you can just show that specimen, and then we'll go ahead for the follow-up. How to follow up this patient? Swastik, you have got that photograph?
No, sir, specimen photographs. I'll show from other device, sir. But
No problem. Meanwhile, can someone answer us how to follow up this patient? And show them the histopathology report also.
yes, sir. So histopathology report was suggestive of a high-grade urothelial carcinoma with still. Just review this.
Sir, one doubt.
Yeah.
Sir, supposedly if the left kidney is functioning, so with the investigations of a suspicious cytology and CT representing of a renal mass, can we just go ahead with nephrectomy, or that barbiturate urine collection or scopy biopsy is necessary, sir?
If scopy and biopsy are unconclusive, right?
But it has to be done. My question.
Once if you have done it is negative, again putting a patient for ureteroscopy and having, we can take the consent with the patient of proper counseling. After proper counseling, he can operate. Or if he's okay, get with the second procedure, whatever logistics are there. If he's okay, then ideally you should have a tissue diagnosis before removing the kidney, either CT guided biopsy or ureteroscopic biopsy, like that.
Okay.
But just because the CT is showing that there is a mass in the pelvis and patient has got hematuria or typical cells, if it is a functioning kidney, we should not remove it.
Sir, I think medico-legally also there should be a tissue diagnosis. If it is not, then again proper counseling, and if we take consent of the patient, it is highly likely is a malignancy and like that, and possibility of if we remove the kidney can be benign or something, then can go ahead, can be done.
Okay.
Without that.
So there are two aspects. One is the medico-legal and second is the scientific thing. So in that case, it is not 100% mandatory that you have to do cystoscopy, ureteroscopy, and have a tissue biopsy. It is not must.
But
it is recommended, but it is not absolutely necessary, na?
Sir, first time we have to attempt to get a tissue for diagnosis.
Okay.
Cystoscopy in such cases is mandatory to
Yeah,
rule out
scopy is mandatory. Scopy is
Scopy we did it. Scopy is one, but to have 100% tissue diagnosis, is it necessary? That is a question.
If
Sir,
cytology is positive and this much size lesion on CTU, then may not be necessary.
Fine. So that is what the question is.
Sir,
Yes,
if
sir.
the lesion is small, then many of these questions will arise. Now, this
Yes.
particular lesion is very large, and anybody seeing that will say, okay, this is cancer, obviously, whether the
Yes.
cytology is atypical or positive. But if your lesion suddenly becomes, say, 1 centimeter with pelvic thickening, then obviously I would need to do a flexible or a whatever ureteroscopy, take a biopsy, and then only go ahead with it. Now, the problem is that if he asked the question which says like if kidney is functioning, if the kidney is well functioning, to change that question a little bit, then the data about chemotherapy in upper tract is evolving. You all know there is a POUT study, which is in the adjuvant setting.
Yes.
And we all understand that in adjuvant setting, there is only one remaining kidney. So GFR is going to decrease. We do not have any idea whether it is going to be cisplatin gemcitabine or carboplatin gemcitabine. POUT study has both the protocols. Okay. So advantage which has been put in a neoadjuvant setting for upper tract urothelial carcinoma is the same as that of bladder, that if you have a good GFR, might as well have a tissue diagnosis and then go ahead with a neoadjuvant chemotherapy, because cisplatin gemcitabine works almost very slightly inferior to dose-dense MVAC. Okay. So, and it is a better chemotherapy than carboplatin gemcitabine. So that neoadjuvant thing in UTUC is evolving. There are articles in Euro Today in 2021, 2022. You read them. Okay. This may evolve in the next 2-3 years now. And finally, it does not evolve so fast. The reason for that is these tumors are rare.
Yes, sir.
You don't see them as often as a prostate cancer or a bladder cancer per se, or a renal mass, which we see many times. So these are slightly rare tumors. So the data evolves very slowly. This is what I wanted to tell you.
Fine. So we did a nephrouretectomy.
Sir.
Now, how will you follow up?
Follow
Sir,
up का अच्छा प्रोटोकॉल लिखा है EU गाइडलाइंस में, बोलो.
sir, follow up for this patient follow up, sir. We will.
This patient and in general, both.
You say high risk का follow up या whatever का follow up, low risk का follow up, दोनों का follow up रहता है.
Follow up is based on the surgery we have choose, whether it's kidney sparing surgery or nephrectomy, and then depending on low risk or high risk, sir. Firstly,
So
I'll
right
tell
now you talk about nephrouretectomy.
nephrectomy in low risk cases, sir. First follow up should be after 3 months. Cystoscopy has to be done after 3 months, then after 6 months, and then yearly up to 5 years, sir, for low risk cases. And for high risk cases, we have to get done ultrasound, CT scan abdomen with chest at the end of 6 months for 3 years, and cystoscopy for 6 months for 3 years, then yearly for 1 year.
Okay, kind of all right. I mean, so what is the role of post-op mitomycin?
It's better to give, sir, within 2 to 10 days in order to reduce the
So there are
recurrence
एक
rates.
दो ट्रायल है ना, उनके नाम चाहिए. एक ऑडमिट सी है, एक दूसरा है. They have shown some absolute risk reduction. How much?
Ashwath, you know answer?
No, sir, I don't know the exact figures, sir.
So to add these few things, you should know the percentage of involvement of PCS system and ureters in the upper tract cancer. Second, percentage of patient having concurrent bladder cancer with upper tract cancer. Patient having bladder cancer, after that develop upper tract cancer, and patient having upper tract cancer and later they develop bladder cancer. These are the examiner's favorite questions I'm telling you. Okay.
Yes.
और जो सर ने पूछा, जो मोस्ट इंपॉर्टेंट मैनेजमेंट के बाद कि पोस्ट सर्जरी माइटोमाइसिन के बाद हाउ मच रिकरेंस is this reduction is there. Okay.
Yes, sir.
So this the numbers you should know, right? And
Yes, sir.
one more thing important: patient having high risk bladder cancer NMIBC who receive BCG, again in those patients the recurrence rate in upper tract is different compared to MIBC and not receiving BCG.
Okay, sir.
Okay, you should know.
Yes, sir.
Yeah.
So Ganesh, you were talking about some clinical research. Can you just enlighten us?
नहीं sir, research नहीं है. मतलब these mitomycin तो is established to be given after nephrouretectomy. In the first, one of the trials was within the first 3 days, and the second trial was within 2 to 10 days. So 40 milligram of mitomycin. I think it reduces the risk of lower tract recurrence by order of, I think, 14 to 20%. I may be slightly wrong. Mahendra, correct me. I don't know.
Sir, up to 30% है इनमें
30%.
up to 30%. But the exact
So
range,
that is-
I don't know.
That is during the nephroureterectomy?
Post.
After that,
Post. 2 days.
recurrence
So
in the
after 10
bladder.
days. Yeah, in the bladder, but after 10 days?
No, sir, not after 10 days, 2 to 10 days. And admit C, I think, was within the first 3 days.
72 hours. Yeah.
Okay, okay. Fine.
Sir,
And
role of intraoperative gemcitabine intravesical.
So that is considered to be given if you are doing a procedure like ureteroscopy or something, because there is a very increased incidence of bladder recurrences after such endoscopies for upper tract. After nephroureterectomy, I have not given any time.
So one question, every high grade tumor, would you like to do nephrectomy? Or in some scenario, you can still save the kidney.
basically he's asking about a nephron saving surgery.
Yes, sir. Sir, kidney sparing protocol can be used, sir.
No, high grade. High grade means
Yes, sir.
high risk.
Understand his question first. High grade lesion,
Any circumstances in high grade lesion, will you be able to save kidney?
Yes, sir.
Hmm?
Sir, if the size of the tumor is small, sir, in the pelvis,
solitary kidney, lower ureteric, high grade mass. What we will do?
sir, distal uretrectomy, segmental uretrectomy, distal uretrectomy will have to do, sir.
Do you have any other option?
No, sir.
So tell now. Imagine
Yes, sir. Patients
bilateral.
having bilateral disease, sir, bilateral
Yeah.
disease. Patients having solitary kidney with the UTUC. Patients having, sir, chronic kidney disease, or patient who are having a lot of comorbidities and poor performance status to tolerate radical surgery, sir. For these kind of scenarios, sir, we'll have to compromise, use a kidney sparing approach, sir, despite high grade, high risk tumors, sir.
Yeah, so distal uretrectomy with bladder cup excision and ureteric reimplantation. This is the one. Okay. As such, segmental uretrectomy and anterior anastomosis. Okay. Is it something very individualized thing? It's not been so commonly done actually. Again, solitary kidney, which is make the patient lifelong dialysis, a small tumor,
Yes, sir.
high grade, then you should do. Otherwise, agar small tumor, he can also forget it and remove it like a low risk disease like that. Okay.
Yes, sir.
Yeah. Okay. So,
Fine.
sir, anything else remaining?
Sir, one more doubt.
No.
हाँ, पूछो, Ajay.
Sir, like repetition of previous question only. In somewhere in the literature, I've read that the role of scopy with biopsy in UTUC upper tract, it's only for risk stratification and when there is a diagnosis suspicion. So is it correct?
So if pathology is positive, and you have a visible mass in the one upper tract, okay, then or it is smaller one, then other than therapeutic, I don't think there is any role of doing scopy. Definitely, because there is a chances of bilateral upper tract. So upper tract, other uterus you have to see.
No, so I will always still do a cystoscopy before I
Scopy is there.
treatment.
Ureteroscopy.
No. His question is related to the ureteroscopy. And cystoscopy is mandatory in each and every case, but ureteroscopy, when your cytology and radiology is equivocal, in spite of having a lesion,
compulsory,
then you have to go for upper ureteric scopy with your URS. Sometimes with the CT urography, the flat lesions cannot be diagnosed, and the biopsy of that particular flat lesions can be taken by doing the ureteroscopy one. Another thing is the selection of the patient for neoadjuvant chemotherapy can be realized with by doing the ureteroscopy, and histological confirmation by taking the biopsy. These are the three important pros of doing the digital flexible ureteroscopy.
Yes.
But the potential risk of doing the ureteroscopy is theoretically it is a diagnosis of bladder cancer as well as cancer dissemination, and it delays the radical treatment.
Okay. Okay. Thank you.
Now, also don't
Okay.
forget the chances of having squamous cell carcinoma, right?
Yes.
Even it
Yes,
is even it is less than 5%, but in the presence of a stone, chronic infection, it may be. Okay, so you have to do cystoscopy, so you have to do ureteroscopy. Being this doubt, again you should attempt at least once to get a tissue diagnosis.
Yes,
So
sir.
it cannot be ignored. It cannot be ignored. Okay.
Right. So we go ahead with the second case, which is quite similar. So Swastik, go very fast and just show all the investigations, and then we ask the question. Just give the history, na, Swastik.
The 63-year female presented with complaint nausea and dull aching pain in the left flank for 3 days. Pain was dull aching, non-referred, no aggravating or relieving factors. It was not associated with hematuria, fever, or dysuria.
Fine. So there was no other positive finding in the history.
No, sir.
Was there? What about that? Just give the positive finding. Go ahead.
Yes, sir. The Karnofsky score was 80, sir. Blood pressure 140 by 80. There is no comorbidities. Hemoglobin is 10.6. Total counts is 9,800. And blood was 1.8 lakhs.
The patient is a diabetic, na?
Yes, sir. Yes, sir. Yes, sir.
You are
Diabetic.
saying no comorbidity. Patient is
Diabetic,
diabetic.
diabetic, sir, and had sir CKT serum creatinine of 2.8 pre on
Yeah.
administration on visiting to OPD, sir. She had a raised creatinine on presentation itself, sir.
Yeah. So this patient had only the pain in the right lumbar region. Okay. No associating findings. She is a known case of diabetes and CKD. Creatinine was 2.8. Fine.
Yes, sir.
Okay. Now, what else in the investigation patient came with?
She had a urine cytology, which was there was no malignant cells detected in this sample, sir.
Okay. And which other investigation?
So CT was done, sir. A non-contrast CT scan was done for this patient, sir. Abdominal pelvis.
Just can you just enlarge and show them?
So this is the image, sir.
Or you can read the final
Yes, sir.
report also.
Final report was a CT KUB reveals significant dilatation of right pelvic calyceal system and renal pelvis. It is associated with thinning of cortex and penephric fat standing. Abnormal soft tissue density attenuation near renal pelvis and proximal ureter requires further workup with contrast study.
Fine. So, Achin, now these are the investigation. This is the history. How will you go about? Achin?
Yes, sir. Sir, right renal considering the given CT films, the right renal parenchyma is thinned out, sir. And I would like to read the CT report.
CT बोला ना तेरे को CT report give. Swastik, again read the CT report.
Sir, an ill-defined soft tissue density attenuation is observed near the right renal pelvis and proximal ureter. However, lack of contrast limits the optimal evaluation. So, and there was a gross dilatation of right PCS and renal pelvis. It was associated with thinning of cortex and penephric fat standing.
Sir, patient has presented with the flank pain, 63-year-old female with raised creatinine, and right-sided lesion is present with thin original parenchyma. I have to evaluate this patient further for with DTP scan to calculate the GFR, and then, sir, we will plan further for operative management.
What are the probable causes of flank pain?
In this patient, sir, or in general?
In this patient, or any patient having a upper urothelial upper tract cancer.
Upper urothelial malignancy causing unilateral obstructive uropathy, and it could be hemorrhage in the malignancy itself, and
Surrounding organs.
pyelonephritis due to obstructive uropathy can precipitate.
And
So involvement of the surrounding muscles in the
yeah, so infiltration.
infiltration.
Locally advanced blockage of lumen. Number 1 is locally advanced. Number 2 is blockage of lumen by the tumor, and number 3 is clot colic.
Fine. So now show the DTPS scan. So again, non-functioning kidney. Ajinkya, now what you want to do?
Sir, I like
No,
to.
there are three things. Already CT scan is done. In
Yes,
last case, we have discussed about MRI and we have discussed
Yes, sir.
about cystoscopy, RGP, and SOS biopsy. In this case, we have no malignant cells seen in urine, and it's a very big mass, and it's a non-functioning kidney. So what are your options? What you will do? You will.
So
There
I
are
can
three
go ahead
things.
with two options. One is if you want to prove what is the lesion which has been seen in the CT, I can again ask to repeat the 3 samples of cytology. I can say it was only one sample which was given. And if it comes out to be, when it comes out to be inconclusive, then we can go ahead with cystoscopy, RGP, and barbitage. Or straight away, as the patient has the kidney is non-functioning, and we can straight away plan for the surgery if the patient is fit for the surgery.
Fine. So, but if you don't get a biopsy, we will do the nephrectomy, or you will do the nephrectomy with the uretrectomy and the cuff of bladder. What will do?
So better to do a radical nephrourectomy with cuff of the bladder, so if we don't have the tissue diagnosis.
Okay. Shashwat, what is your take on this?
Yes, sir. Yes, sir. It's a non-functioning unit, sir. If we are not able to get a tissue diagnosis, it's better to presume that it is a transition cell cancer, sir, and proceed with radical nephrectomy with the cuff of bladder and template-based lymph node dissection.
So Shashwat, only upper tract tumor can give hematuria. Is it not possible renal cell carcinoma invading the PCS can give hematuria?
Definitely, sir. But renal cell cancer, sir, is predominantly an endophytic growth in into the PCS only till the upper ureter is less likely, sir.
So
Then
where did you find in this imaging and ureteroscopy that it is a pure PCS lesion, pelvic lesion?
So the renal contour appears maintained, sir, in cross-sectional
Yeah.
image.
If tumor is the hilar area, maybe the central part, contour will be maintained.
So, but considering the function of the kidney, like as it is non-functioning, so it is better we can consider
Cannot
it.
be stricture with the renal mass. It's to hydronephrosis, or not possible, not at all possible.
Could be, sir. It could be. There are other possibilities like fungal wall.
I just want to try to this thing. Whenever you have such scenario, have a broader thought. Okay, this is a class of upper tract, right? So why are you focusing only on the upper tract? There are multiple causes of hematuria. Or if I would, until I will see the proper diagnosis about this, okay, I will not label as a upper tract cancer.
So this patient didn't
Patient
present
did
with
have
hematuria.
hematuria.
This
This
patient
did have
presented only
hematuria.
with pain, sir, no hematuria.
Exactly. So why you are labeling him as a upper tract cancer?
So not
But in
we
CT they
can
have
have
mentioned.
try getting we can try getting
You don't have contrast. You
repeat
don't
cycle.
have MRI. CT has a contrast. Anyway, they have written as a contrast relation is mandatory, is necessary.
The creat is 2.8.
Yes. So is it no, there is no role of if ureteroscopy is negative or unconclusive? We can't do a biopsy.
Oh, that's what, sorry. We can go ahead with two. One is the cytology was only one sample, so we can repeat the cytology again. If that is also not positive, then we can do a cystoscopy and biopsy. And then when that also comes out to be inconclusive, we can do an ureteroscopy and get the tissue biopsy.
Yeah. So ureteroscopy, so you want to do 3 invasive procedure versus 1 biopsy from the lesion USG guided.
Coaxial biopsies can be taken.
Can be taken.
Yes, sir.
So in this case, with Mahendra, you feel that ultrasonography guided biopsy will be helpful?
Sir, if the report 2 or 3 times ureteroscopy things are negative, not conclusive, and we suppose that if in ureteroscopy we can't see any definite lesion, and in the imaging, because we don't have any imaging, either MRI, we can do MRI, target the lesion, and then we can do a biopsy, either ureteroscopy or the USG guided. Because again, in this case, tissue diagnosis is important. Whether to, if suppose that it comes as a RCC, then it's over treatment. Removing the bladder cavity is over treatment. So we should know what are we dealing with actually.
CT plate एक बार लगा दो sir, please.
Swastik CT scan लगा.
Plate.
पीछे
Yeah, if you see, if I can see at the 4th image, it cannot be a lower pole mass with hydronephrosis.
Yes.
And this image, pelvis is normal. If I see the last image, I cannot see anything other than the something like PUG obstruction like that.
If you see the second and third image, there are some filling defects in the pelvis. On right side. There are some intraluminal lesions.
Yeah. So what are the chances of metastasis if it is not renal cell carcinoma, and if we take a biopsy, then what are the chances?
Sir, if we do with the coaxial technique, it's almost zero of seeding of the tumor cells.
Okay.
Nowadays, I think everywhere, good institute, they are only doing coaxial biopsy. Nobody is doing just putting needle in the mass.
Usually, the RCC is a parenchymal tumor that is arising from the cortex. So majority part of RCC is towards outer side or periphery, and when it reaches to the reaches towards the hilum and involves the perivascular system, then it should present with the hematuria. Common presentation.
Yeah.
So this is a classical teaching. Now here there is no hematuria, only pain probably. That's what, if I am not wrong.
Correct.
And CT is suggestive, as Mahendra says, if you see the lower pole, it looks like a lower polar mass and hydronephrosis. But if you go through all the CT films, picture number 2nd, 3rd in first row, there are some intraluminal papillary frond-like masses floating inside the lumen of pelvis. So here, if possible, if your cytology is again negative, so here if you go with flexible scopy and try to do a biopsy of that particular lesion with upper tract cytology, that will be the great idea for to have a diagnosis, provided that
Okay.
patient general condition is fit for that particular surgery. If
Okay.
I am wrong, please correct.
Yeah. But in this case, as such, we are going ahead with the nephrectomy because it is a non-functioning kidney again. So
Sir, here,
again,
in spite of non-functioning kidney, the limitation of the dissection we have to decide. So for that particular point, we should have a diagnosis prior. If it is a
okay.
non-functioning kidney, then how much ureter you are going to remove? If the radiological picture is of high-grade TCC of upper tract or RCC, if you are suspecting RCC, then okay, then no need of any biopsy. But if you are suspecting a TCC, then there should be some diagnosis. Yeah.
So now the difference between the first and second case is here because it appears to be low polar mass and there are some remote chances of it being RCC. We are recommending biopsy. Correct? Am I right, Mahendra?
So
Yes, sir. And sir, second option, if not, we can do a frozen also. We can do a nephrectomy, do a frozen. If it is TCC, complete the job in the same setting. The another option.
my simple
Okay.
question to Mahendra as well as Ganesh sir, is it worth to do a one trial of flexible scopy in this?
Sir, no harm. No harm.
Suppose if we are doing something and if there is a trauma to the ureter, then what are the chances of
So we
settling
can
and
also
other
think this way that this is totally non-functioning.
Correct.
Then, as Mahendra said last time, no, explain the patient and take a call.
Yeah.
So, but sir, how much ureter you are going to remove?
हाँ sir, वो
Which
frozen भेजना
particular-
पड़ेगा. I was
That-
going to come to that.
That's frozen,
Kidney primary diagnosis के लिए put the facilities of frozen, prime the pathologist, and if you, we should generally they are able to tell us gross diagnosis. Then go ahead with the ureter.
Sir, they can tell confidently TCC or RCC. They can tell this confidently.
नहीं urothelial बता देते हैं. I have done twice अभी.
Fine.
Because-
So in this case, yeah, one thing is because it is appearing like that it can be RCC, you are saying that biopsy can help us. Or second option is you do nephrectomy, do a frozen section, prove that it is urothelial carcinoma, go ahead and remove the ureter with the cuff. Correct?
Yes, sir. Because sir, this is an indication of renal biopsy when it is equivocal diagnosis on imaging.
Fine.
Yeah.
Understood. But otherwise we are going ahead. And
Yeah.
And it is not necessary because I feel in this case, sometimes I am little worried that we do rigid ureteroscopy and we are actually it is under pressure because we forcefully put there's a water inside the saline inside the system. Then what are the chances when, because it is an obstructed system, there is a mass in the upper ureter, and I'm sure that must be definitely some trauma to the wall. So many times we have seen the extravasation, and mainly in such cases where there is a pathology. So by doing ureteroscopy in such a big mass, what are the chances that we may do settling?
Sir, first of all, ureteroscopy to be done with the flexible, not with rigid. And the complication related to the flexible ureteroscopy is preferably there are some injuries. Yes, it is possible. And the chances of sepsis. Only 2 complications. So sepsis is very rare, 0.3 to 0.6%, and chances of perforation or avulsion or some injury to the mucosa or injury to the ureter at narrowed side, it is approximately to overall complication rate is 1 to 2.6%. And as far as cancer dissemination is concerned, there is no any significant difference with or without URS. If you have done URS and if you have not done URS, no significant difference in overall survival as well as the recurrence-free survival.
Fine.
So if you are going with a digital flexible scopy, then there are chances of injury in any procedure.
Correct. Yeah. The only question is that because the mass is so big and it is totally obstructing, and as such we are going to remove this kidney, irrespective whether it is malignancy, no malignancy, because it is a big mass and non-functioning kidney. I think this second approach which Ganesh and Mahendra has suggested, that will be the better, that you do nephrouretectomy as much as you can, send it for the frozen, and if it turns out to be positive, do up to the cuff of the bladder.
Right,
Agreed. Provided that frozen section facility is available.
Correct. Fine. So what is the histopathology report, Swastik? Swastik, do we have histopathology report?
We don't have.
It is there, no? Upper track.
True, sir. Not provision.
See, now there is a subtle rise of creatinine. Initially, it was 3.8. Now, after I think 3 months, 2 months are over. Yeah, 3 months. It is 7.2. So, Achin, now next what?
Next, sir, regular follow-up or rising creatinine. We have to evaluate, sir, patient again, sir.
Sir, we have to evaluate whether the patient is developing hydronephrosis on the other side. There could be contralateral upper tract tumor with hydronephrosis. So we have to
See,
first.
one thing you understand, patient is a known case of CKD. Patient has got a diabetes. Probably it is a diabetic nephropathy. It is a progressive, must be a glomerular disease.
So, sir, one question, sir. A patient having creatinine of 2.8 to start with. So
Yeah.
she must be having a nephro consultation regularly, I guess.
Yeah, she was under nephrology. But not actually. They see these patients, they know that their creatinine is raised, but they don't take much advice.
Okay, okay.
You know, not regular.
I think we just have to rule out the surgical cause of a high creatinine and just I don't see anything special in this scenario.
Yeah. See, we have done the ultrasonography, and it is showing that neph kidney is just corticomedullary differentiation is
Not well.
decreased. Yeah, it is little decreased. It is decreased, and it is a bright kidney.
So
That is
maybe
the
in
thing.
between, yeah.
It could be, sir, that the patient is having, sir, pyelonephritis, because in the DTPS cancer, we have removed a non-functioning unit. And after removal of a non-functioning unit and without a surgical cause or any hydronephrosis, sir, the creatinine is not expected to rise exponentially, sir. In the
Why?
Sir, because sir, that the unit which we removed, sir, that was not contributing significantly to the overall function, sir. So after nephrectomy, if the after surgery, if the creatinine is rising, we have to rule out first of all any hydronephrosis, any surgical cause, any obstruction. Then secondly, sir, we must evaluate whether the patient has developed any pyelonephritis, which is could be the cause of rising gradually rising serum creatinine. And if none of the above is found, sir, then we can label it as a chronic progression of the chronic kidney disease, sir.
Yeah, so it is. I think it is going into the end-stage renal disease.
Yes.
So when can you do
no surgical
transplant?
cause.
Yeah, there is no surgical. So when can you do transplant now?
After 2 years, provided genetic syndromes of other malignancies have been ruled out after 2 years of current malignancies.
So in all cases, will you do, or some specific cases?
Actually, sir, it is a high-risk advanced disease, sir. So the follow-up period is about 3 to 5 years, sir. 3 years is strict follow-up, sir. 6 monthly. So I think, sir, we
So
should.
exactly, to be very frank, in for every oncology, there are strict recommendations of renal transplantation. Okay, because it based on the disease profile. Chances of recurrence, if it is high, then it is not recommended. For example, if I give you about the RCC, so again, RCC, if it is in low grade disease, Furman grade 1 or 2, which basically Furman grade 1, T1 is stage disease, definitely within a year, transplant can be done. But when there is a high grade disease, 2, 3 or 4, and unfavorable pathology, transplant is not recommended in kidney cancer.
Yes,
Okay. So again, I don't know about the upper tract, but I think again, it's a high grade disease. So I think there is a something period of 3 to 4 years. If there is no recurrence, then can be considered, because we are taking precious organ from one other normal person,
Yes, sir.
right? It should not go waste. At least it should work for 15 years
Yes,
minimum.
sir. And most recurrences, they occur within the first 3 years, sir.
Yeah.
So
So I don't know the recommendation about this thing. It's a very important question, but maybe because of rarity of disease, maybe the answer we also getting answer also difficult.
yes, sir.
Maybe Gite sir said, sir add something about transplantation, or Gaurang sir add something about transplantation in this scenario, upper tract cancer, high grade.
Yeah, no, I think in upper tract we should wait for, because such a big mass, there are all chances that, just now it is not appearing. In this patient, actually, I'll tell you, when we did the surgery, it was so difficult. Everything, duodenum and vena cava, everything was like not seen only. It was totally covered. Like, after
Okay.
how you see in pancreatitis, one case of pancreatitis I had done, and I had to abandon the procedure. So here also it was almost like that. But we were able to get the plane between all these things. And that time only we realized that this is definitely going outside the kidney.
Then again, sir, if it is a T3 disease, then no point of offering a transplantation.
No, in this case,
Not at
nothing.
all.
But
Not at all.
forget about that. If it is only the kidney which is involved, still I think we have to, in this case, we should wait for 3 years.
Yeah, minimum 3 years without recurrence.
Yeah,
Okay.
fine. Anything else?
Only, sir, they can enumerate the approaches for kidney sparing surgeries. If they, that is the important part. I think that
Yeah,
is the
there
only
is one question on nephron saving. Yes.
Yeah.
In upper tract,
Approaches.
there is a nephron saving surgeries. So there is one question. Can someone answer that?
If you're considering it for like, we will divide it into renal and ureter. So for ureter, if it is in the upper two-third, and if it is low risk, we can go with ureteroscopic and then fulguration with the laser, or we can do a segmental resection. And if it is high risk, we'll have to go ahead with the radical nephrectomy. Similarly, if it is in the distal third of the ureter, we can go ahead with the URS, or we can do a distal uretrectomy with bladder cuff excision, and then anastomosis of the ureter and bladder. And similarly, if it is high risk, then go ahead with the nephrectomy. In case of kidney, either it is in the pelvis or either in the calycial. If it is in the calyx, we can go ahead with the flexible URS and do similarly like fulguration with the laser. And if it is in the if it is low risk, if it is high risk, we straight away go ahead with the right radical nephrectomy. And if it is in the pelvis and low risk, then again we can go ahead with URS and try to even UA guidelines say you can go percutaneously and try to exercise that for as far as possible. And if it is high risk, we will go ahead with nephrectomy.
So the ideal way to answer this question is in exam. If somebody asks, it's doing surgery, so you should start with the endoscopic thing first. Basically, of the renal pelvis part first. Okay, like laser ablation, excision from the this thing, only cutting current. We can do the URS or RIRS like that. Then percutaneous, we can do that. Then you come to the open. So better to come from the, because renal pelvis tumors are most commonly done with the endoscopic management.
Endoscopy.
Right. So this, and no need to say if it is not done, we will do radical nephrectomy. It is understood. Your question is nephron sparing surgeries. That's all.
Yes.
So in a nephron sparing surgery, how you should go around is that if it is in the ureter, Okay, you will do ureteroscopy and you will find out whether is a sessile big broad base or a small pedunculated. Okay, then best thing is to dislodge it if it is possible. If you can't do it, one thing is by the cautery you can just cut it, or you can use the laser, or you can use the Domia basket. You can go above the tumor, go to the pedicle and just crush it and try to remove it. Once you can remove it, you can just ablate the base from where it is arising. If it is in the pelvis, then we have got two options. One is to do percutaneous if it is little bigger, or you can go along with the RIRS, same thing in the calyx. So that is, you are saying about endoscopy. And then second will be to do either small resection of the ureter and ureterouretic anastomosis, reimplantation of ureter, like that. Okay.
So there are two important input has been given by Gite sir and Bakshi sir. Okay, read it, and whatever Dr. Bakshi sir put in the group, it is the question can be asked in the exam, like as the TCC is the seeding tumor. What maneuver will you do to avoid tumors into surgery? So in renal pelvis, during manipulation of the kidney, your first job is to mobilize the ureter and apply the clip below the tumor. So when you mobilize the tumor or the kidney, the tumor seeding will be no or the minimal, like that. Okay, this is the how the tricky question maybe examiner may ask, the practical aspect. Okay.
So there is a paper published in European Urology in 21, which says immediate post-op installation of mitomycin after nephroureterectomy. But the conclusion is very clear, which says that it is safe procedure. So they have actually not evaluated the BRFS in that.
I think any other questions?
One question to Ganesh Bakshi, sir. Sir,
Bola sir, yes.
digital rectal examination shows bilateral palpable hard nodule and PSA 100.
Sir, upper track में.
This is a related different question.
Okay, okay.
So my question here is MRI or MP-MRI?
Sir, if you are expecting metastasis with 100 PSA, then you can say MRI. But otherwise, now we should come to recognize the fact that MP-MRI is to be done before prostate biopsy. Because gradually evidence is evolving towards doing only targeted biopsies, although it is not the guideline today. Today we have reached a stage where we are at MP-MRI and systematic biopsy plus targeted SOS biopsy. So there is one more catch question in that. So why MP-MRI? Because if you want to select targeted biopsy areas, MRI is difficult to answer that question. Many times I go to my radiologist and ask him, what is this? Is there a plane between near the rectum involved with cancer? So that I would take the prerectal fat plane and not the Denon-Villiers plane. So he says, wait, I cannot see on only T1, T2 and contrast. I need to put a DWI and ADC, and then he tells me, okay, this is not cancer. Whatever fuzzy plane you see is not cancer.
So two palpable nodule are already there.
So palpable nodule is like two things. If they are palpable like the knuckle of your wrist, then technically it is DRE wise clinically T3, possibly. But MRI is still the best. Between MP-MRI and MRI, I don't think there is a great cost difference also today.
That because why I'm asking, same defense I have placed during that mock exam, and this question was discussed there.
So I think most of the examiners in DNB as well as MCH should now probably graduate to the fact that MP-MRI is a better investigation.
I agree.
Because you don't know, you are saying that presentation is 100 PSA. It's a hard nodule, fine. Suppose if I have a diagnosis of cancer also, I still treat him with antibiotics and tomorrow that PSA comes to 17. Will you not consider surgery as an option?
Agreed, sir.
So
Hello.
that is-
Sir,
Gite sir.
follow.
Dr. Huddegar from Karad.
Bolo, sir.
One question to you and Dr. Ganesh.
Bola, sir.
Suppose we have we are having this SOIL in the kidney and we are in dilemma RCC or TCC, and we are posting the patient for nephrectomy, radical nephrectomy. We have completed the procedure of radical nephrectomy with subcostal incision. We have removed the ureter as low as possible and kept the identification mark there and closed the actually incision. Because the this frozen section facility is not there, so we waited for HPR report. The report came as this TCC. Then we took Gibson's incision. Within 8:30, we took Gibson's incision. Then identified the ureter, and along with the cuff of bladder, we removed the part. Is it okay, or you?
Provided that your first histopathology report is high grade, then it is okay.
Suppose it is
Ganesh
low
sir.
grade, then.
Ganesh sir.
Yeah, but urothelial है ना आपका?
TCC.
TCC.
Okay.
They
Sir,
don't have frozen facility.
Frozen की आपके पास facility नहीं है. I
नहीं
guess
है.
you should still try for a coaxial biopsy or a FNAC or something to try to prove your urothelial.
Right.
Sir, already they have done a nephrouretectomy. They don't have frozen section. Whatever possible ureter they are able to reach, they are removed along with nephrectomy. And
So,
now
उसमें गड़बड़ क्या होती है सर मैं बताता हूँ. Many people do that and sometimes these patients used to get referred to Tata Hospital. Now the problem is not only about that left out ureter and the bladder cuff. It is always, if the tumor is in the upper ureter or renal pelvis, it is about the lymph node dissection.
Yeah.
So if he has not done a lymph node dissection, it does not matter to me. I'll have to do the whole surgery again. So that's why I said, it is best that you have a tissue diagnosis in some way, alternative to the frozen, and then go ahead with a planned surgery, or then refer to somebody else rather than doing a disservice to the patient.
Correct.
And we have given chemotherapy and operated for our RPL-ND. Mahendra will remember these things. Because of such patients later on develop nodal disease in the para-aortic and retroperitoneal area. So what happens is patients never go back when they present with such kind of findings. They go to another doctor. मेरे से आपके पास जाएगा, आपसे किसी और पे पास जाएगा, ऐसा होता है.
Right.
So correct. Okay, sir.
Okay.
चलिए, good night.
Good night.
Good night. Good night.
Good night.
Good night, sir. Good night.
I think today last few questions were really very good. Thank you very much, Mahendra and Ganesh.
Yeah.
Many doubts are
Welcome,
clear.
sir. Welcome, sir.
Yeah.
Good night, sir.
Thank you.
Ajinkya sir, kindly in the session because of your network error, you
Okay,
are a
okay.
host.
I'll end.